and some guidance concepts for mitral intervention. So we'll talk a little bit about pathoanatomy that's suitable for mitral repair, highlight some of the technical and imaging practices that have extended some of the patient pool that we now consider, and introduce some new guidelines. So think back to the Everest criteria. This was the landmark study in transcatheter mitral valve repair, going back 20 years now. 10 years now, a little over 10 years ago. And it was very specific about what you could do. You had to go down the middle, A2, P2, stay away from the medial and lateral. You couldn't take on gaps that were too big, flail widths that were too wide, very specific. There was only one size of clip. And I show this because this is sort of the mindset. These are the easy ones of today, but they're certainly not the limits of today. And I'll come back with some details. So patient selection for transcatheter edge-to-edge repair, there's a lot of different sort of published slides. They're all a little bit like this. And this is important because it highlights all of the factors. You have some clinical factors. Is it primary MR or secondary MR? Have you done and completed all the guideline-directed medical therapy, particularly for FMR, secondary MR, that can truly have a profound impact and improve with the right medical therapy? Have you had the surgical interventions and other things like CRT to get synchrony? Gone through all of that. Then you talk about the operators and the teams and the sites. What's your experience? Have you done complex cases? Have you only done easy cases? So that's all sort of the experience level, beginner, intermediate, or high volume. And then we get back down to the anatomy finally. And this is where those screening TEs that get sent to the reference centers become incredibly important. The data has to be contained there. So the optimal or ideal cases for edge-to-edge transcatheter are still those that were defined in the Everest study a decade ago, right? And this is a central, no calcium, a diastolic valve area of at least 4 centimeters squared, and then some restrictions on the leaflet size and gaps. Fast forward to the far right, which are the most challenging cases. Some would say prohibitive, depends on experience and whether they're truly prohibitive. So calcium within the grasping zone, very small areas. This is less than 3 from our experience. Diastolic valve area of less than 3.5 centimeters by 3D planimetry, we generally won't do. We've not had success going below 3.5 centimeters as an area. And then other sort of, and Barlow's is another one, big, billowy leaflets that truly look like sails. You have 6 scallops flapping in the wind. Those are tough ones for an edge-to-edge repair. Those you really want to have a surgical intervention if it's at all possible. But guidelines. So these are the guidelines in terms of how do we get to the decision-making around these patients, right? So this is for primary MR, leaflet pathology. You go down this path. So it's got to be severe, got to be symptomatic, should be high or prohibitive risk. That's unlike TAVR. We haven't gone down to moderate or low risk. These are still patients that are generally the first thought is surgery because there's no transcatheter therapy that's yet as good as a good surgery. So when you can have surgery, still surgery. Patients hate to hear that. But if you can't have surgery or you're prohibitive risk or high risk, at least carry on down this pathway. That's when you consider edge-to-edge repair. So the more challenging group that we deal with is the secondary MR, the functional group. And this is an example. It's a slide Paul Graber gave me some time ago. And this is sort of the extremes. Okay, so on the far right, you've got perhaps an EF that's maybe still normal, a strategically important infarct, maybe a papillary muscle dysfunction and some focal tethering. The MR is severe, but overall the size and function of the ventricle isn't terrible. The far left of this is the end stage, the massive LV, terrible EF, low strain values, and transplant, hospice. And somewhere along this continuum, a transcatheter intervention is going to be futile. But where is the line of futility? And this is the challenge. We understand this concept that in some patients it will help, and in some patients it won't. But when the patient's in front of you, is the line here, is the line down here, and who is the patient group and the phenotype where an edge-to-edge repair treating the valve is not going to be helpful when it's a ventricle problem. So the secondary MR is a much more complicated story. The primary MR is much easier. And despite that, we have guidelines on secondary MR. So much like I showed you before, similarly, it's got to be severe. You should have persistent symptoms after guideline-directed medical therapy, favorable anatomy, and here we have some sort of borders on what's reasonable. So the EF less than 20, most would say probably not going to be helpful to do a mitral intervention. EF greater than 50, question your diagnosis a little bit. Is this really secondary MR or not? Very, very dilated LV, mitral intervention is probably not going to be durable and helpful. But if you go down that pathway and thinking an edge-to-edge repair is a good thing to consider. So let me show you a couple of cases. This is the worst type of patient. This is a retired physician. Retired physicians either want to know everything or they want to know nothing. It's a difficult group. So retired physician, dyspnea on exertion, you can look at his valve. He's got both focal prolapse and this thick shelf of calcium under his valve. He's got significant MR. And if you look at the 3D off fast view, this is what my father would call a dog's breakfast. It's just an ugly, ugly valve. Technically, I think it's a Carpentier 3A, but it's all just an ugly valve. So can we land a clip on that safely? Probably, certainly not in the Everest study. They would have said absolutely no. But today, with different size clips, team experience, the answer is yes, it's possible to put a clip on this. So 2 clips deployed, some mobility, a little bit of color left over, still an ugly valve, but now we have a clip over here and some color. And again, as I talked earlier, how much color is too much? Are we done? Is this mild, moderate, or severe residual MR? Again, we look to hemodynamics. So at baseline, we have a small S-wave inversion. We have an S-wave resurrection. And we actually have a very happy patient with 2 clips. So this is an example of what is a contemporary anatomy that can actually be treated reasonably with good outcome with transcatheter repair. But we still have this sort of spectrum of consideration. So if somebody's had a prior surgical repair and with all of the caveats about perturbed flow that we just heard about, the options now are for a redo surgery. So sometimes decades later, sometimes years later, unfortunately, sometimes months later, you can do redo repair. You can consider transcatheter edge-to-edge repair. And of course, we've also now got the new angle of a valve and ring if they have a surgical ring. This is an example of somebody who had a prior surgical repair. There's often a consideration that, well, there's already a undersized ring. You're going to put a clip there. You're going to make that flow area even smaller. The presence of the ring is an absolute contraindication to an edge-to-edge repair. That's generally not the case. So one of the issues is the ring is at one level. The clip is further down in the ventricle. It's not in the same 3-dimensional plane. So it's not immediately going to be obstructive. This is an example of a very nice tissue bridge from a clip in a post-repair situation and no residual MR. And we had a nice study a little while ago. Nicholas Van Meegen ran this, and we participated with several patients, 100 consecutive patients who'd had prior surgical valve repair, almost all with rings. And of those, we had we sort of evaluated, and on average, 5 years post-surgical repair, 90% device success, technical success. And we sometimes used ICE. Most of the times you had to use off-axis imaging, but it was entirely feasible and very select patient group who did not have posterior leaflet resection. P2 has to be there to clip it. But if they have not had a P2 resection or a significant A2 resection, generally just an undersized ring, then it is possible to do edge-to-edge repair following surgery. So again, a patient group that was excluded from Everest, but we're sort of expanding the scope of who can be treated with these transcatheter therapies. So edge-to-edge repair, TEER success, thoughtful patient selection, absolutely. An imaging protocol, we talked a little bit about that this morning. Approach to problem solving, a lot of different sizes and devices, and team experience still matters very much. There is a diastolic valve area that I think is still an absolute limitation to going below that. Technical success is possible certainly in primary and usually in secondary MR therapy with TEER, but clinical success, I think, is more obvious in primary MR. In secondary MR, you can usually get a very nice clip. You can often get an MR reduction, and occasionally the patients feel no better. And that's because you're treating the end-stage ventricle. So you have to be somewhat cautious about how sick is the ventricle if you want to try to get rid of the MR. So the TEER targets today would be very unlike what they were in the Everest study. I think almost all of these exclusions are no longer exclusions, with the exception of very small valve area. Okay, so changing gears a little bit. TMVR, the term that can encompass all of this with some confusion. So just to clarify terminology, transcatheter mitral valve replacement can mean valve in prosthetic valve. It can mean valve in prior surgical ring. It can mean valve in a native valve, which is one of the most anatomically challenging situations. And it can mean valve in MAC. So there's lots of calcium, which acts like an anchoring ring. I can't go through all of those in the time allotted, but I'll go through one case of valve and MAC, which I think highlights some of the imaging features. So this was a 73-year-old woman who had severe MAC. I love showing this video because it doesn't matter if it doesn't play, it looks the same. But this is a circumferential annular calcium. Believe me, there's a little diastolic orifice here. Mean gradient, my fellow measured at 10.5. I would have called it 11. So severe MS. The thinking was, could be surgeons, of course, evaluated prohibitive surgical risk because of all kinds of significant comorbidities. Okay, not a lot to do here except medical therapy or perhaps a valve and MAC. So the thinking was, could we take a transcatheter valve designed for the aortic position, the TAVI device, turn it upside down, stick it in the mitral position. You have to do a transseptal puncture to get it there. You have to hope that the anterior leaflet doesn't get pushed into the LVOT. And that's the thinking. So this is valve and MAC procedures. The way we generally screen and evaluate these patients is with CT, of course, with echo. The general thinking is if the CT predicts after you've done a digital overlay of a transcatheter valve into the LVOT that you have an LVOT size that is at least 170 to 190 millimeters squared, that's sort of a consensus number that fits some, then the risk of your neo LVOT is not going to be compromised and you should be able to get the patient through the procedure. That's sort of a reference for you and lots of discussion about what the size should be. Nevertheless, in this patient, the projected valve area based on the CT overlay of a transcatheter valve was that her neo LVOT would be less than 130, much less than the threshold. So thinking, okay, if we tried this in her, we will obstruct her LVOT by pushing her anterior leaflet into the LVOT. That's not the outcome we want. What else could we do? So we heard about the hemodynamic consequences of splitting the anterior leaflet. And this is now something that's happening with catheters. So this is a procedure that has a name. It's called the LAMPOON procedure. So this is a form of catheter-based electrosurgery. The idea is, on the little graphic on the right shows this, you sort of create a rail with a catheter, you denude a little V-shaped part of the catheter, you position it, and with the right timing, outside the body, you electrify the catheter. It has a wire running through it. You electrify the wire, and then as you pull on the electrified wire, it will slice, like cautery, right up the anterior leaflet. So you're sort of like opening the curtains before you display the curtains into the outflow tract. So this is called the LAMPOON procedure. It's been done now many times. This is us doing that procedure. So you bring two catheters into the left atrium through the transeptal here. This is sort of one, catheter two. You deploy one at the base of the anterior leaflet, and then you have to make a puncture. So when you burn through the base of A2, so now we have one catheter goes right through the base of A2. The second catheter is through the natural orifice. This is showing here. So now we have a little hole here. You can see that flows abnormal through the base of A2. Then you create a rail. And then this is the fluoroscopy moment. The interventional cardiologist loves this. You see also, incidentally, this circumferential MAC. That big cloud is all the calcium. This is the V. And then the image on the right is sort of the money shot when you pull. This is when you slice through the anterior leaflet. Anesthesia gives the patient a breath hold. Everybody in the room does a breath hold. And you hope that you've only sliced the anterior leaflet, but there's so much calcium, it's hard to go wrong in theory. So now you've opened up the curtain. The anterior leaflet is no longer a single sheet that's going to obstruct the LVOT. So then, having done that, now you can deploy the sapien valve, in this particular case, balloon expandable valve, into the MAC, and this is the valve deployed. So in somebody who did not really have a surgical option and had refractory symptoms and heart failure, this is the idea. I'm an echocardiographer, so I'm going to show you the echo pictures. I can go through most of this. This is the balloon expansion. This is the image after the sapien valve deployed in the mitral position. And this is sort of the color shot. I do note there's a little bit of posterior paravalvular leak. That's quite common because you think about the force counterforce we just learned about. There isn't as much calcium up front. So the valve doesn't have something hard to push against in the anterior, but tends to make a weaker contact posterior. So a little bit of 6 o'clock position posterior PVL is fairly common in these cases. So this is the baseline. This is the post. This was a case from last year for us. This sort of summarizes multimodality imaging using CAT, CT ultrasound, digital deformation modeling for the overlay and determination of the neo-LVOT, real-time 3D guidance, catheter-based electrosurgery, and beating heart valve implantation. I would like to Show you a couple things here. So what are we finishing with? We have a little bit of PVL, and we have, as expected, a left to right shunt because we have to get to the left heart. Leaves a big iatrogenic ASD. In this case, we're not going to close it. We're going to leave that hole because the flow is going left to right. In this patient, that's thought not to be a bad thing. So question we always have is this little bit of PVL going to be a risk for hemolysis? Probably, because you have a very hard calcium in front and a ring at the back. But we decide to leave it. We all celebrate. We know high fives. You never do high fives. We think we have a Disney finish. The birds are singing and everybody's happy. I'll wrap up. In short, this was a Stephen King finish. 2 months later, she's back. The PVL is obviously much worse. So we've had some recoil. And this is the challenge with the field of trying to put valves that are designed for the aortic position, the mitral position. They're too big. The surface area is large. This is not a singular experience. We thought, well, we could just plug this. We've done that before. Here we've got a plug. We position a plug. Things are looking good. Getting a plug across. The plug's in the wrong spot. It's in the middle of the valve instead of at the edge of the valve. Lesson learned, it's much easier to put a catheter and a plug on the edge of a surgical valve than a transcatheter valve, which is a meshwork of frame, and you could easily slip inside the frame and not realize you've done it. So slipping inside the frame on a PVL repair of a transcatheter frame is much more challenging. That's the valve. We thought we were beside it. We realized we'd done this sort of maneuver, so we had to go back and keep trying this, a little bit of fussing to get a PVL plug. Anesthesia is now telling us patient's not doing well, getting hard to vent, blood pressure's falling. What's going on? Our shunt that went from left to right is now moving to right to left. We realize in all the PVL work that we're doing, we're holding open the ASD that we had created. So we're actually allowing greater shunt. Now the shunt is reversed from right to left. Hemodynamics aren't happy. We started this sort of the circle of badness. So we become hypoxic, PA pressure goes up, RV function gets worse, TR gets worse, shunt gets bigger. Oops, that was for emphasis. The whole spiral of bad things that are happening in this case. So then the enemy of good is perfect. So let's just get out of here. Let's put an ASD occluder, stop the shunt. That's all we can fix in one day. But lots of lessons learned for valve and MAC therapy. It's still very much a forefront, challenging. The imaging is sort of thinking on your feet and recognizing problems as they develop. The LAMPOON procedure, I did want to introduce this. That's sort of one of the things that's opening up options and leaflets. PVL after MAC, valve and MAC is very common. Iatrogenic ASDs need to be respected. They change. You've got to keep an eye on them. I remember when MAC was always the surgeon's problem. And now we have to deal with it. There's some guidance on this. It was a review we wrote a little while ago on sort of some of these imaging principles. And just to finalize sort of the TMVR, like TEER, requires success features. Valve and ring, band, and transcatheter valves can now be performed. I'll stop there. Thanks very much.